Welcome to the Physio Matters podcast, this month in association with exerciseprescriber.com, and this is session 50. Hello everybody, welcome back to the Physio Matters podcast for yet another milestone episode. This time we've reached half a century, 50 episodes. I can't believe it myself, but never mind. If you're worrying where the dulcet northern tones of Mr. Chew are, they've gone on honeymoon and left me, his southern doppelganger, in charge, Jack March. This month, we are absolutely delighted to be bringing you, once again, Toby Smith. You'll remember him from sessions 35 when he discussed all things osteoarthritic hips. A really brilliant clinical episode, which personally I found really useful. And this time we've invited him back to talk all things OA knees. Rob Tyre does a brilliant job with this interview, and I think that you'll find it really clinically applicable. Have a listen out for the newest member of our podcast team in the background of Rob's recording. Well done to him for managing to spawn another child, and we are planning well into the future. So when we are too old to continue doing these podcasts, we have a new set of employees ready to come up behind us and take over the mantle for maybe episode 100. Who knows? Let's see. On that note, why not check out our Patreon page? Just go patreon.com and search for Physio Matters, where you can donate us a little bit of money. You might have noticed if you've been on our website recently that our servers keep going down, and we could do with investing in that scenario. So we have no money. If you could provide us with just a little bit, that would go a long, long way to helping us keep all of this going and keep it coming to you for free. While you have a listen to this episode, me and the rest of the Physio Matters podcast team are going to have a little bit of a meeting to see how we can maybe get Chewy to shorten his questions while he's not here and give us a bit of a budget for a party every few weeks. So we'll see you on the other side when you've listened, and we'll have a little bit of a debrief.
Okay, so today we've got Toby Smith on the podcast, who you may remember from about a year ago, I think it was, when we talked about osteoarthritis of the hip and the precautions following surgery. And this session today is going to be a little bit different in that we're going to talk about the condition that we commonly see in clinical practice called osteoarthritis of the knee, if we're still going to call it that. So first things first, we'll just get you over to Toby, and if you can, Toby, can you kind of update us a little bit on where you've been, what you've done since the last time we met?
Yeah, no, absolutely. It's great to be back. So over the last year or so, I've moved jobs. So I've moved from the University of East Anglia. I'm now based full-time with Professor Sally Lamb's group at the University of Oxford at the Nuffield Department of Orthopaedics, Rheumatology and Musculoskeletal Sciences. From a work perspective, really continuing my interest and passion around trying to investigate and better understand musculoskeletal diseases for older people. So the work around hip fracture, the work around osteoarthritis for the hip and the knee has continued really. And I suppose for those listening and those interested in osteoarthritis of the hip and the knee, we've continued as a group to work on our knowledge around physical activity promotion for people with hip and knee osteoarthritis, but also what we can do for people after hip and knee replacement as well. So I've been interested in looking around physical activity measures, how we can promote physical activity, but also actually promoting wider physical activity, so social isolation and loneliness, and trying to address those factors so that patients really can view physical activity in that wider perspective about just being active in their everyday lives, really. So fair trance of research around that. I suppose the other thing that people might be interested in is I'm currently working with Professor Philip Conahan in the University of Leeds as part of the OMRAC group. So this is the outcome measures in rheumatology trials. And as a group, an international collaboration, we're developing the core outcome set, or revisiting the core outcome set, for measurements for people with hip and knee osteoarthritis. So the first part of that work is to work out what domains or areas we should measure in for people with osteoarthritis in clinical trials. And then the second thing, which will be commencing really from May this year onwards, will be to look at what instruments or measures do we use to measure those areas. So hopefully by May we'll be able to tell you what clinical trialists and clinicians should be measuring as a broad area. And then after May, in a couple of years' time, we'll be able to tell you what are the best measures to use in people with hip and knee osteoarthritis. So, yeah, busy boy at the moment, but loving every minute of it.
Sounds like it. And could you just repeat the title of that piece of work? Was that?
Yeah, so that's the OMERACT group. So if people are interested, they can go onto Google and type in OMERACT. So it's OMERACT. And it's an international collaboration that was developed about 20 years ago, which combines clinicians, rheumatologists, physiotherapists, occupational therapists, orthopedic surgeons, but also with patients, with epidemiologists, and with people that develop outcome measures and evaluate outcome measures as well, really to bring together all the knowledge that we can to determine what outcome measures should be used and are best to be used for trials, but also for clinical practice. So it's a really exciting time to really better understand how we can work out outcomes for this patient group.
Sounds great. Sounds like a juicy piece of work.
It is. It's one of those that it's rolled on and on and on. So I started it nearly 18 months ago. So we looked at a series of systematic reviews to determine what the evidence was. We're currently running a Delphi exercise to gauge and Canva's opinion around outcome measure domains across the world. And the final part of this phase is to meet in Sydney in May 2018, this year, to get consensus across the wider international group about what we should measure. So, yeah, it's given me some grey hairs, but it's been thoroughly enjoyable. And it's a really rewarding piece of work because we know at the end of it, actually, it's got real value to both clinical practice, but also to researchers as well, to really better understand patient outcomes.
And has that got something to do with what I've seen buzzing around Twitter recently about joint replacement thoughts from clinicians on who would benefit a knee, hip, and a shoulder replacement?
That's slightly different. So I mean, that's you're absolutely right. We're currently bouncing, trying to get social media involved around promoting the Delphi exercise. I think the other thing that's going on concurrently at the moment is the NICE guidelines are advertising for their committee. So the NICE guidelines looking at hip, knee, and shoulder replacements are developing their guideline committee, which will hopefully better understand the elements of what should be in the pathway for hip, knee and shoulder replacement. So I'm fortunate enough to be a member of that committee, and what we're planning over the next 18 months, because as many people will know, NICE guidelines are rigorous in how they're developed, but also have lots of consultation phases as well. So outcomes won't be until March 2020, we anticipate. But what's really important and what's bouncing around social media at the moment is trying to get a really valuable network on this committee so that we can, again, get opinion from physiotherapists, from occupational therapists, from surgeons, but really importantly from patients as well, so that we can really say at the end of it, these are guidelines, they're really valuable, they're applicable to all the important stakeholders, and therefore we can then use this to base clinical practice upon. So yeah, there's lots going on.
Great stuff. So I took us off on a little bit of a tangent there, and so we're going to try and bring it back into the order in which we discussed we'd go through this. And I suppose the first thing that would be quite nice to talk about from your perspective, because it can sometimes be overlooked in a clinical perspective, and that is the natural history of someone who would be classified as having an osteoarthritic knee, or a symptomatic osteoarthritic knee, shall we say. So in your mind, what's the sort of biggest clues for you when someone walks into your clinic room as to, this is, I think, what we're dealing with?
Yeah, I think it's. I mean, there'll be no surprises to most of your listeners here. From my perspective, it's really marrying up the patient, the clinical history, but also the differential diagnosis. So first port of call is these patients will often walk into my clinic in some stage who are aged 40, 50, 60 and above. They might or might not have had a history of trauma in a long time ago, but the first rule that I have is, can I exclude any other condition? That means actually it's more likely that I'm diagnosing an osteoarthritic knee. And the textbook cardinal signs are, pain on weight bearing, are early morning stiffness to 25 to 30 minutes, and with very mild effusion without an obvious history of acute trauma. So they're the big things, and they're, as again, standard textbook answers, really. I think the important thing is particularly to make sure that we're not missing anything. So if there's anything that we should be aware of in relation to red flags, if there's anything in relation to overt meniscal or ACL injury, particularly for the younger patient. But also, I suppose, the other thing is just differentiating between any other weird and wonderful things. So is there been a patellofemoral dislocation? Has there been some osteochondral lesion? Because our management might be very different for that population. So yeah, it's just excluding. Diagnosis by exclusion. But yeah, your cardinal signs are, this gradual onset, this pain, particularly on weight bearing, and the early morning stiffness are the big signs for me from an osteoarthritic point of view. I think age can be really difficult because we're always taught and encouraged that our patients will come into clinic and they'll be aged maybe 50 or 60 of osteoarthritis. But that isn't always the case. We do see the younger degenerative knee, but then there's a school of thought that says, the vast majority of knee pain in your 40-plus-year-old will be of a degenerative nature. But again, it's making sure that there's nothing that we're missing so that we can't either manage ourselves in a different way or refer on to our surgical colleagues if that's indicated, really. So,
yeah, that's certainly what, in my experience, what I've been led to believe as well, that it's to consider a 40-year-old knee onwards, then there's likely to be a degenerative process there. But let's try and unpick that a little bit if we can then, because we've got a lot of research in several different body parts which suggests that these degenerative changes are tantamount to grey hair and wrinkles a lot of the time, signs that we're just getting a little bit older. And what I tend to say to some people, if they're the right person to take that, is that this is just evidence you've been alive under gravity for 40 years or 50 years or whatever it may be. I'm mindful with some of the great information you gave us last time about not to belittle people when we're talking about, it's just grey hair and wrinkles. But if we can unpack that a bit and say, well, the NICE guidelines suggest that osteoarthritis of the knee is a clinical diagnosis rather than a radiological diagnosis. However, when I get people coming back from secondary care, it's often the case that it's been a radiological diagnosis, and certainly some surgeons will x-ray every knee that comes into their practice because they feel like it needs to be graded. I mean, where do you sit on the whole, from day one, patient enters your clinic room, they've got knee pain, are you thinking imaging at this stage, or what? Are you purely thinking history and clinical examination findings?
From a degenerative knee, I subscribe to the clinical picture, because there's a wealth of evidence which says, whoa, actually, if you base your diagnosis solely on radiological evidence, you're going to miss a big chunk of patients. So we know that there'll be a large proportion of patients that will have mild, if any, radiological features, but still have clinical osteoarthritis. They've got a clinical need. We have to do something about that clinical need. To say from our perspective, no, we're not going to do anything because actually you haven't got radiological evidence is a difficulty. I think it's changed over the last 20 years, and both from a surgical perspective and from a non-surgical perspective, it's changed. I think from the surgeon's perspective, and I'm not a surgeon, but I think surgeons will probably feel more comfortable about operating when they've got both. So they wouldn't consider doing a joint replacement if the patient is completely asymptomatic. They probably wouldn't see them if they're asymptomatic. They're coming to them in clinic or to us in clinic because they've got a clinical need. Whether that is then supported, reinforced, validated, whatever the term is, by radiological features, then is a very different thing. I think from a physio perspective, we feel very comfortable about actually it's a clinical feature. I think the other thing is the point about the grey hair factor, and that, you know, is a really interesting point. I think the way that I look from it, I originally completely agreed with that. I was like, yes, actually, you know, this is just natural joint change. So there's joints in the body like the temporomandibular joint, the wrist joint with the triangular fibrocartilaginous complex. You know, these wear out. So in 50, you will have a hole in your TFCT. That's a natural feature. Do we have these natural features as well in other synovial joints? And the only thing I'd suggest is that whilst a lot of people have osteoarthritis, and you know, a lot of people, if we both radiologically and clinically scanned, a big proportion of people in their 50s, 60s, 70s, there'll be a lot that have spinal OA, we call it, or back pain, for instance, so up to 100%. There'll be a lot of people that have hip and knee OA, but there'll also be a lot of people who are in their 60s, 70s, and 80s who don't have hip and knee OA, but they've still been active. So, and this is where the uncertainty and the confusion lies, really, because, you know, we all get old, hopefully, but some of us develop osteoarthritis clinically and radiologically, but then some of us don't. And I think we're getting, definitely as a evidence base, we're getting cleverer and smarter on working out the phenotypes, so the type of patients who do and who don't. But we still don't know. There'll be those people in their 70s and 80s who are absolutely fine. But why do they avoid it? And why not? So factors such as genetics, factors such as trauma, maybe factors such as diet and lifestyle certainly play a feature in that. But there's also factors such as metabolic relationships. So, you know, I've always been confused, interested around how some people have osteoarthritis of their thumb, which is one of the most common joints in the body to get degenerative changes. And if you look at the data around BMI, for instance, people with high BMI have high osteoarthritis of their thumb, but they might have no osteoarthritis in their hips and their knees. But traditionally, we think, okay, hips and knees, they're weight-bearing joints, high BMI, more weight. Why aren't we developing osteoarthritis there? Because the whole body surely is susceptible to osteoarthritis, potentially, from a chondrocyte matrix sustaining homeostasis perspective. But in reality, it doesn't seem to happen. So why does the thumb get it and not the hips and the knees? And I think we are getting better at working out what happens from a metabolic perspective, from a homeostasis perspective of the joints, but we still haven't cracked it. The body's still keeping some secrets about why some things happen and some things don't. So the aging thing's tricky. And I think that's why, you know, the first question about, well, when the patient comes in, you know, how do you know if they're going to be OA or not? You know, unfortunately, they can't give us this phenotype about those risk factors. And we know there are certain risk factors, as we've mentioned, but we're still not quite there with certainty around that. But yeah, it's a tricky thing. And I think if we were smarter on being able to work out, identify people who are at risk, and we've got some indications who those people are, but if we were really confident with the at-risk ones, then could we do something early on to prevent it? Because it seems that once they've got osteoarthritis, then the options for managing it are challenging, either from a surgical perspective or from a non-surgical perspective. And whatever happens is repercussions for that patient for the rest of their lives.
Yeah, I mean, myself, I'm often finding myself chasing things around in circles, as you mentioned. We've got somebody who, you know, has a 70-year-old knee, comes in, has an X-ray from the GP already, and it's pristine, but yet has clinical features of what you'd consider an OA knee. So is there an argument to maybe move away from the term OA knee in the absence of radiology and maybe something more generic like knee pain?
I think it's really tricky. I think because there's two things we've got to consider here. There's one is from a clinical perspective. So, you know, from a clinical angle, are we all singing from the same hymn sheet? So are the physios, are the rheumatologists, are the orthopedic surgeons, are the occupational therapists, are we all singing from the same hymn sheet or not? Including all the other professions as well, primary care, secondary care, tertiary sectors. So that's one thing. So actually gaining consensus around what we all agree of knee pain is is challenging. I think the other thing we have to consider is around patients. So some patients subscribe to the term osteoarthritis. If we then start using a term such as knee pain, that might have positive or negative connotations. So some people might say, okay, well, it's aging pain, and then they might belittle it. So they might not take their management too seriously. And maybe the term osteoarthritis puts it into a clinical mold. So maybe they perceive it slightly differently. And the perceptions of osteoarthritis from a patient angle are really interesting. So if we look at the qualitative evidence, there's some suggestions that unlike other diseases such as heart disease, such as blood pressure problems, where people are incredibly compliant with their treatment. So if you have high blood pressure, hypertension, a lot of patients will take their blood pressure tablets because the consequences of not doing that with a stroke or cardiovascular disease are horrendous. But if you look at people who take pain relief for osteoarthritis, they'll dabble a little bit, they'll change it around, they might not be too compliant. There's a lot more flexibility and they feel in control for that. Maybe because the consequences of not taking those tablets might be a flare-up in their symptoms, but it's probably not going to kill them.
Yeah, I've never heard someone say, I'm not taking my blood pressure medication because I don't want to mask the problem.
Absolutely, absolutely. So the perceptions around terminology and nomenclature around condition are really difficult. So I have to admit, in this perspective, I'm a little bit old school. I would keep it to OA just because actually we've got consensus and we're getting more consensus around OA from a buy-in from the patient's perspective, but also from the clinical community as well. But I agree, I think, and there has already been a shift around actually looking at not just clinical outcomes, not just radiological features, but clinical features as well. And that has happened. I think actually from a physio perspective, from a rehab perspective, from whatever angle that is, be it sports therapy or physio or whatever, actually we feel very comfortable about this. Whereas I think some of our other clinical colleagues, they still would, feel comfortable about having that radiological feature or not.
But I suppose it all boils down to what that person in front of you understands by the term osteoarthritis, because a lot of it, it's the end of the line as a term for people. You give them that label, then they consider, oh well, maybe there's no point doing anything about it. I've just got to ride this out until I get a new knee. Whereas somebody else who's like, oh yeah, my granddad had it, he did all right. So I should be okay as well. So I think it's horses for courses personally. I do flip between the term osteoarthritis. I do flip between the term mechanical knee pain. I do flip between the term knee pain. I think it just depends on the day you catch me. So I think there's maybe a little bit of inconsistency within the same clinician, not just within professions.
I think the other thing is, I suppose, it's the person in front of you as well, really, because I think it's whatever term we give it, we then have to follow that up with some education, support, advice, with a positive, motivating spin on it. And I think if we use the term osteoarthritis and don't follow up with that, then there's a danger that the person's going to leave and have a very negative connotation of that. That will then will then mar and affect their whole perspective of their condition and potentially their prognosis. They're also at the whim then potentially of going on to Google, and then that might be good or bad depending on what site they visit. So I think it's challenging, isn't it? It's whoever you've got in front of you and making that judgment call, really, but also giving them the tools to be able to then use that information in a constructive and positive way. I think is very important.
Definitely, yeah. I think that discussion needs to be had, and sometimes can't be done in one session. Maybe requires follow-up, even if that follow-up is more discussion and more chat. A good solid plan in my mind is more useful than anything else. So you've briefly touched on some of the other questions that I had in mind, and I don't know which one to go to first, if I'm honest, because they were both quite interesting. You mentioned obesity, and we'll kind of put that into a comorbidity umbrella term. And how that some people who are overweight don't necessarily have radiological changes in their knee, but do in their thumb, which may suggest a more systemic, dare I say, inflammatory process. You've got to be careful here, because that's often the fallback generic diagnosis, or we're going to get rid of the inflammation with your problem. And then you mentioned stuff about diet as well. Do you find that there is more and more of a shift in the research going towards a more metabolic understanding of osteoarthritis rather than a pure mechanical stress?
I I think I'm going to sit on the fence here. I think both.
You did last year as well. I was hoping you were going to change.
No. Well, I mean, it's similar in the respect that there's phenotypes and there's still phenotypes. So I think there are definitely some people that have the more mechanical based osteoarthritis. I think there's some people that have an inflammatory element to it, and I think there's people that have a combination of both. If we just look at those factors, and I think it makes perfect sense that we have a condition that presents very, very differently across lots of different people in lots of different joints. Some patients, they'll have periods of remission where it'll flare and it'll go down, it'll be good for a bit and then it'll flare and go down. There'll be some people where actually we've got a very aggressive, progressive type of osteoarthritis that will just come on very quickly. It makes sense then that actually the pathophysiology of the condition is probably very, very different, and there's a number of potential mediators to that. The diet thing is interesting, and I've been fortunate to work with an international group, including Brendan Stubbs, who's based at King's in London, and we published last year a couple of papers looking at diet and its relationship to osteoarthritis development. With the Osteoarthritis Initiative data sets. This is a data set with over 4,000 people based in the States. And what we found was that those people that have a high inflammatory index diet, so this is like a pro-inflammatory diet, so starchy foods, sugary foods, that sort of high content diet, they were more likely to develop and present with osteoarthritis, clinical symptomatic osteoarthritis.
They were, or they weren't, sorry.
So they were. And the flip side is then there's a separate analysis that we did when we looked at people that had the reverse of that sort of diet. So the reverse would be the conventional Mediterranean diet, which has a low carb-based element to it. So in that population, that seemed to be almost protective of osteoarthritis. So those people with a high Mediterranean diet seemed to demonstrate that they had a lower propensity to develop osteoarthritis, clinical symptomatic osteoarthritis. So from that alone, and there's other studies around as well, suggest that actually there is a dietary element that could be involved in some case of osteoarthritis in some people. And this was a cohort of 4,000, so chances or not in that instance that the diet could be a factor.
And I don't mean to quiz you too much on something that was written a year ago, but if you can recall, were the populations similar in the sense that those people who had a high carbohydrate, starchy, sugary diet, were their demographics similar to those who had a Mediterranean diet? Because my thoughts would be, as a confounder, would they not necessarily be a different background? People who actively participate in diet will have a positive outlook potentially on the way things are going, which we know can have a mediating effect on pain. People who maybe are overweight, maybe have some comorbidities of low mood and anxiety, which again has a negative impact on pain. So was that looked into? Was that controlled for? Or?
No, yeah, absolutely. So we controlled for the obvious factors around age and gender and factors like that, but you'd have to go back to the original papers. For the life of me, I can't remember. Okay. And that's always one of the challenges, isn't it? It's about, particularly with this heterogeneous population, is trying to control for every factor under some. I think the basic ones I think were covered, but you'd have to go back to the source paper.
It's certainly interesting that, because from a mechanism point of view, I wish it was black and white, that, oh, look, all you have to do is we'll cut some of this out of your diet, we'll add some of this into it, we'll do a little bit more exercise, and Bob's your uncle. But I think, I suspect it's probably a little bit more complex than that. Which I suppose brings me on to the next point. One of the team members, Mark Reed, I don't know if you've come across him, was interested in your take on the terminology of exercise prescription and the use of exercise by physiotherapists. And I know you mentioned at the start, I think you maybe quite deliberately, the term physical activity rather than the word exercise, because classically we give out quote unquote quads strengthening exercises, and I know that I've had people with knee pain that classically seems osteoarthritic, that they don't actually have any strength deficits on on testing or functional things like getting out of a chair. It just hurts. So where do you sit in terms of the activity provision for people with a symptomatic knee?
Yeah, no, absolutely. I think you tailor it to the patient in front of you. So in the instance where your patient actually doesn't have any strength deficits whatsoever, then straight away the prescription of restorative strengthening programs isn't needed. So it's then thinking, okay, well, what is needed is some form of activity. And it's something that's meaningful and that they can habitualize into their lifestyle and fit in and do constantly. And I think the thing with osteoarthritis is that when the patient comes to clinic, there might be times when actually, okay, well, we need to address the biomechanical factors here. So is it weak? Is it stiff? What do we need to address? Then there'll be a period of time potentially where it's then saying, okay, right, we've addressed that deficit. You've got a long-term condition here that we know activity and exercise will maintain, improve, whatever, from a joint perspective, irrespective of all the other benefits which exercise can provide. It's at that point that the exercise prescription from a therapeutic exercise then might modify and change to okay, well, let's be more active. What do you enjoy doing? And fit the activity to what they enjoy or can fit into their lifestyle. For some people, and as clinicians, we all know this, some people actually, they'll look at their therapeutic exercises, which could be quad strengthening, it could be hamstring work, there could be proprioceptive exercises, whatever we prescribe. Some people will look at that as a medication prescription and say, okay, right, in my lifestyle, twice a day, I will do these exercises, and they'll fit to that religiously. Whereas some people that just doesn't really work for. And again, it's the same in exercise prescription, whatever the joint. It's then looking at your patient and working out, at the end of the day, I want you to exercise and be active. How am I going to be able to motivate you and encourage you to do that now, but also long term as well? And that's where the skill in the way for exercise prescription comes in, and that ability to modify and change that. So I'd view it in those two ways, really. Probably the best way of putting it.
And would you consider the effects of exercise away from the site of pain in some cases? Maybe not necessarily using the legs. Some people want to do upper body weight training, for example. Is that something you consider in your prescription?
I think if you've got a pathological entity at your knee, then I think at some point they'll need to do some movement and exercise to that area. So, having said that though, if they've cycled to get to the gym to do upper body stuff, then that's great. And I think, it's being clever and creative with your exercise prescription though. I mean, at the end of the day, if someone says to me, actually, what I really enjoy doing is painting. I really like painting, and exercise just doesn't really interest me. So it's then, with the clinician hat on, you think, okay, well, how can I modify that? So it's okay, well, what do you like painting? Well, I like doing landscapes. Okay, right. Well, to get to your landscape, what do you have to do? Okay, well, I go in my mobility scooter and I get around there. I was like, okay, well, could you park your mobility scooter a bit further away and then walk the last bit? Or, what's stopping you? What are the barriers to be able to do that? Oh, well, actually, I feel unsteady on my feet. Okay, well, we can do something to help you, be it exercises, activities, be it walking aids, whatever, to be able to facilitate that, really. And I think that's where the creativity of physiotherapy and rehab professions is really valuable. So, it's that creativity, really. But at the end of the day, I'm a big believer about people should be active, and we need to be really clever as healthcare professionals to work out, well, what can we do to support that and facilitate that, but also to maintain that as well. And people won't do stuff they don't want to do, as we all know that. So it's just trying to work out what's meaningful for them and to do that.
And I suppose that's when it becomes a conversation rather than a lecture, in terms of engaging that person to become more active or modify their activity level, shall we say. So we're going to move on to an area which it's benefited me in clinical practice in some ways, and I think it's maybe held people back in other ways. And I'd like to get your take on the NICE guidelines. Personally, I've found the revised, updated version from 2014 much more useful than the previous one. It seems to have a bit more of a flow to it in terms of avenues to explore and tiers of treatment, etc. But you often come across a little bit of pushback. For example, the quote I've heard is, well, they're guidelines, not tramlines, and I've found benefit from using acupuncture for OA knee, etc., etc. Where do you sit in terms of the NICE guidelines and in your clinical practice? How do they sort of fit with you?
Yeah, I think I'll put my cards out early. I'm a big fan. I'm a big fan, but from a clinical and a research perspective, I think they really work in our favour as healthcare professionals, I'd like to think, because what they do is particularly if we take the 2014 OA guidelines, is they acknowledge that patients are different, and it does a very holistic approach to how we manage patients and to identify all the potential biopsychosocial factors that could be involved in that patient care. But the key thing, I think, is that it bases the decisions and the recommendations on evidence. And it's very easy for us in physiotherapy particularly to be tempted to not be so evidence-based in our approach. So it really fosters that evidence-based recommendation so that we know that what we're prescribing for our patients is justified and is based in good quality evidence. So the core recommendations about exercise, weight management, self-management and advice, but also about analgesic recommendations, they are based in good evidence. You're absolutely right. There's other interventions such as acupuncture which aren't recommended. There's other interventions such as TENS, which is recommended as an adjunct. I think bracing is an adjunct as well. And that's basically saying, okay, well, the evidence base doesn't support that. So when we've got only a certain amount of time with our patients, unfortunately, in many areas of clinical practice, let's give them the best that we can give them. Let's give them an evidence-based intervention and then deliver that. I think the other thing which I'm a big supporter of with the NICE guidelines is that they acknowledge that there is inequalities in evidence in clinical practice potentially at the moment, but there shouldn't be. So these are national guidelines that says actually wherever you are in the country, whatever your demographic, whatever your background or characteristics, you should be offered these interventions, and these are the core interventions. So particularly in this current climate where services are being stretched and we as clinicians are being limited in some instances about what we can deliver for our patients. Actually, we've got a document here and guidelines here where we can stand up and say, look, this is what the evidence base says. This is what an NHS, NICE organisation have rigorously conducted 2 years worth of work, and this is what we should be delivering for our patients. Because sometimes there is a mismatch. I think from my perspective, the interventions, and most people will look at the interventions and choose the interventions. The interventions, in my view, actually, knowing the evidence base, seem really sensible and would be the things that I'd do in clinical practice. But if you look at the rest of the guidelines, and the bit I'm really interested in is around what should happen as a follow-up. So these patients should be seen, and then a lot of patients, i.e. those that have continuing symptoms or have more than one joint problem, they should actually be then reviewed again. And they should be seen at 1 year, and they should be seen regularly. And that's the bit that frequently gets missed, because it's very easy to see our patients, to send them away with some education, with some advice, some exercises, with encouragement to do and to change. But then we don't see them. And that's because either our service can't provide it or the numbers are too big for the service to be able to provide. But actually, we're not following NICE guidelines because they recommend that somebody should be seeing this patient group again. But it's very hostage driven. They are hostage to either them going back to their GP or being re-referred to the physiotherapy, or they just take the mindset, as we said earlier, about, okay, well, this is OA knee, it's aging, my dad had it, they had a grotty knee, I've just got to get on with it. But actually, there might be services that we can provide in therapy to be able to actually improve their symptoms so they can do more. So the long and short of it is I'm a big fan, and I think we should actually cherish it, and we should use the NICE guidelines to really support and to stamp home about what we can offer for this group of patients that are often, in all fairness, neglected, either because we can't provide the service that we want to provide them, or we choose interventions sometimes which aren't actually the most appropriate, which we should try to avoid.
And so one other thing that I'd like to sort of ask you about is, because as you, I'm a fan of the NICE guidelines, but let's try and put you on the spot a little bit then. And what could be done better about the NICE guidelines? And what I suppose I'm asking is, what do you think is going to change in the updated versions that come out?
Yep. What will change? I mean, the things that I think will change based on looking at what's on the horizon from a research perspective, because I think only things will change based on evidence, which is reassuring, really. Things won't change with passions or viewpoints or perspective, and also things shouldn't change because of the current climate of healthcare provision in the UK. Things should really only change because there's an evidence base around them, hopefully. So if we look at that, I think the big sway will be from a physio rehab perspective, will be around this self-management support aspect. So if we look at the evidence over the last 5-6 years or so, there's a growing body of evidence around actually physiotherapists and behaviour change approaches. So we know that exercise, we know that weight management, we know that taking their medications are really beneficial. And probably every physiotherapist will know, yes, I've given these interventions out, but my patients just don't take them. They just don't adhere to them. And they come back and they're either, not interested, or they can't fit it in their lives, or their symptoms are too sore and too problematic where these aren't applicable to them. And I think, if anything, what I consider NICE guidelines looking at is around, well, what is adherence? And what should physiotherapists particularly be able to encourage and support our patients around adherence with behaviour change approaches? That's the thing that I think could change. I think the evidence base is growing in that area. The question is the evidence base compelling enough by 2018, 2020, whenever the next update's out, to be able to really foster an argument that this should be in the review or not? And likewise, all those interventions that we just discussed, which aren't supported as core interventions, if the evidence base comes out with good quality trials that this is supported, then they will change. But as far as I know, I don't think the evidence base is radically changed in those areas that we've mentioned that would change that at the moment. But I'm not on the committee. We'll have to wait and see, and we'll have to wait and see what the evidence base looks like as well, because that's the important thing. They
Fair
don't
enough.
change guidelines willy-nilly, so to speak.
All right, so not based on the Daily Mail. They don't change guidelines.
Not yet.
No.
No.
Fair enough. So if we can, then let's try and pin some of this on a clinical scenario. So let's say we've got a 50-year-old gentleman who's walked into your clinic, hobbled into your clinic, we'll say. He's not walking with an aid. He's hit and miss with these analgesia. He's had knee pain in one knee for about 3 months. Not particularly disturbing his sleep. Works as a builder. Used to be a quote-unquote footballer, and then goes on to tell you about the trials that he's had at regional clubs and how it fizzled away to nothing. Where are you starting in terms of your thought process between conservative care, self-management, regular physio input, invasive techniques, investigation? So the whole host of things that can be offered for this gentleman. What's your thought process so far?
Yeah. Okay. So as we mentioned before, his diagnosis by elimination. So making sure that actually the clinical profile in front of me is a degenerative knee.
Let's say it is. So let's say there's no red flags with this gentleman, and there's no potential for anything nasty to bite you in the backside.
So from an intervention, then it's really working out, okay, in very simplistic terms, what is this guy's problem? So what are his problems? Can we make a problem list, and can we link that? And again, if we based our intervention on the NICE guidelines, we can go to that NICE schema which NICE provide around the holistic assessment of OA, and I'd anticipate that we can always use that as a menu and work out, okay, from this list, or actually from my clinical reasoning, what are his problems when we discuss that between the two of us? Can we link those problems then to treatments with goals? And time again, I'd anticipate that around exercise activity will be one feature. It sounds like discussion around medication, with a potential review of that medication is important. A big feature, which would be core to that whole first consultation, is around education. It is around explaining the condition, explaining how it happens, why it happens, busting myths, explaining what's key, and really explaining about what his outcomes could be with the various different routes for management.
So let me stop you there then, Toby. I'm your 50-year-old gentleman,
Yeah.
and I'm interested in this process. Can you give us your best patter, your best spiel about what you tell this gentleman about his suspected diagnosis?
Yeah, so the clinical feature, so his knee indicates that structurally there are changes from which look towards osteoarthritis, and arthritis of the knee joint, which is a loss of cartilage, and the bone tries to recover and to harden up, which might stiffen up, which might lead to pain because you lose some of that cartilage. Therefore, there's nothing to protect those pain sensors being sore. But the key thing in really preventing this getting worse and managing your symptoms is around movement, is around offloading that joint, but also keeping comfortable so that you can do those two things. And I think it's explaining really to the gentleman around that those two factors will be there forever. And actually, if you have a period of time when, say, you have the flu and you're not so active, your symptoms might flare up temporarily. But it's making sure that you return back to that level of symptoms. The key thing, I suppose, is this discussion around analgesics, because in my mind, there's the two features that really will indicate about whether this patient's going to do well or not are, first of all, around his education of his condition, his self-efficacy and his mindset. And the second thing is around the severity of the symptoms. So that patient might be, might subscribing to osteoarthritis very clearly, might understand that actually this is the condition. He knows what he should do, and he's got all the attributes to be able to do that from a knowledge perspective, but his symptoms are just preventing that happening. So actually it's too sore to exercise. It's too sore to get moving, for instance. And actually that's where the analgesics come in. The weight management is difficult, isn't it? But I think when patients come in with a condition that is painful and they've had it for a while, actually it's an open book. It's an opportunity for that physiotherapist to say, well, actually, there's an evidence base that suggests that if you take some of the pressure off your knee joint, then there'll be less pressure on that area of exposed bone, so there'll be less pain potentially. And I think that's really powerful for the osteoarthritic joint, because patients will often be able to understand that. They can picture that in their mind. Actually, if I've got less force going down it, then it'll be less painful. So it is a real opportunity to encourage that, because the other thing that we then know is that, well, to lose weight is that combination between exercise and activity and diet. So again, it's fostering this healthy lifestyle choices. And again, it's that open opportunity. So my first port of call really is to manage conservatively. For your patient in that scenario, it'll be managed conservatively. If we hark back to the NICE guidelines, they would always argue, okay, well, the patient has to exhaust conservative management before anything else should be considered. I think that's absolutely right.
So because then let's talk about the exhaustion of those conservative measures. Sorry to cut you off there, Toby, but let's say the same gentleman's come in and he's had his leaflet from physio. He's done 6 weeks of intermittent static quads and inner range quads, and he's put an ice pack on every now and again and took his medication. Me personally, I don't see that as an effective exercise prescription. But so then let's say he's been he's had robust input from physio. He's done everything that we want to do, and he's come to you and he said, "Look, I think I want to go down a knee replacement route." What's your discussion sound like with that gentleman then?
Absolutely. I think it's the exhaustive nature. So if everything's exhausted and they've had a good rehab program and they've looked at all the elements and their symptoms are still problematic, then that discussion really would be, okay, well, what is the level of your symptoms? Does it stop you sleeping at night? Does it stop your occupation? What's that level of disability at the moment? Because it's then weighing that up with, okay, well, the surgical route is once you've gone down that route and you've had a joint replacement, then you've had a joint replacement. There is no turning back at that point. That joint replacement will last 10 to 15 years, and then you're then in a pathway then of needing that joint replacement to be revised, and so forth and so forth. There are inherent risks with any operation, and there's inherent risk with operating again and again and again and again. There's a risk of infection. It's a once you're there, you don't go back type route. So it's a big decision first of all, for that patient to make about, well, how are my symptoms? Can I manage my symptoms with my current lifestyle, with my current occupation, around my sleeping capabilities? Or actually, are my symptoms really affecting my quality of life to a significant level where I would consider this? I think in that instance where they would consider that actually it's having a detrimental effect on my quality of life, my overall quality of life, I've exhausted non-operative management, that's the instance where I'd say, okay, well, actually, if you really feel that compelled about it, then it might be worth having a chat with a consultant orthopedic surgeon at this stage, if that is the case or not. But I think arming the patient with all the information at your disposal for whatever the physiotherapist or clinician in front of them, at the level that they feel comfortable about having that chat, is really important. So that the patient then can try to understand, well, actually, it's a big jump going to the surgeon, because the surgeon really will operate. That's what they're interested in. The non-operative management, well, that's the physiotherapists, the OTs, and the rheumatologists. The surgeon has a very clear, defined role. Now, it might be that the patient then goes to see the surgeon and then actually, after having a further chat about it, decides that isn't the right thing for me. Or the surgeon might say, actually, I don't think this is the right thing for you at the moment. Or they might say, actually, yeah, it is the right thing for you at the moment. We're happy to do that. But I think, again, arming that patient is difficult. I think the real challenge is that some patients, you're right, will have this preconceived idea that I've got knee pain and I just can't actually do the conservative thing to get rid of the knee pain, and I want to be able to do all the things that I want to do. I want to improve my lifestyle and my quality of life, and that's really difficult.
And that's more the real life patient. I've given you two examples there, which were, I think, arguably quite kind. The decision's been made for both of those, really. So the grey area is that person who's come and they've done a bit of conservative treatment, they've got their mind set on a knee replacement, they don't want to take tablets, they want their quality of life improved. Or say, for example, they're 65 and they say, all my parents and family died at 70, 75, I don't see me lasting much longer than that. I want my last 10 years, 15 years, what have you, to be good quality. And that's the juggling act. And one of the questions I have for you is, where do you see your role in terms of your contact with that person to help guide them to a decision of whether a knee replacement is the right thing for them or isn't? And do you see that as purely the surgeon's role, or do you think that physiotherapy has an ability, rather than just presenting the information, to actually say to somebody, I don't think you're going to do too well with a knee replacement, or I think it is the right thing for you to do?
Well, I think the physiotherapist's role in this instance is certainly to do that. I mean, I think, for an experienced physiotherapist, they can make that judgment call about, okay, well, you've exhausted lots of things, you've done everything, and this is the situation. You could go down the two routes. I think what I personally try to avoid is telling people. So I try to avoid telling people, you need to do this, you need to do that.
You set yourself up for failure somewhat, don't you? And the surgeon turns around and goes, no, I'm not replacing that knee.
No, absolutely. And I think, so I'm very much about, okay, well, based on my clinical experience, this is what would happen to you if you did this. This is what would happen if you did that. However, at the end of the day, I'm not the person with the scalpel in my hand, and it's not on my head if it it doesn't go too well. I think knee replacement, well, both hip and knee replacements have massive implications about what happens for the rest of that patient's lifestyle and the rest of their patient's life. The thing with the knee replacements still, and we should never forget this about knee replacements, is that 20 to 30% of them will have continuing pain. So actually, it's not a quick fix. The knee replacement still will have a 12-month to 24-month potentially period of time where you're rehabbing, where you're still recovering. It just takes a long time for that knee to settle. And as I said, in up to a third of people, it might never settle. But you know that you've got that knee replacement in there, and that will need replacing at some point. And so that's a big decision. I think the other thing that I think physios also forget, and patients often forget, is only about 20 to 25% of people with osteoarthritis of their knee will need to have a joint replacement. So it is still only a quarter. So there's 75 to 80% of people that don't go down the joint replacement route. So we know that it can be managed, or patients decide not to go down a surgical route and to change their lifestyles to incorporate pacing or whatever the reason is. So it's a very, very individual decision that they make, really. It's a difficult one. But
well, I'm glad you brought up the stats on that, Toby. Because I'm glad you brought the stats up on that, because I looked at the stats, and or I think I did at least a few years ago, and correct me if I'm wrong, because I may just be remembering this incorrectly. The NICE guidelines, I believe, suggest that 33% of people get better, 33% of people don't get better, and 33% of people get worse. That, for me, that 66% isn't a particularly good outcome. So 2/3 of people either get worse or no better at all. Does that suggest that we're maybe, or my stats are wrong, or does that suggest that we're maybe not picking the right person for the knee replacement?
I think the thirds thing, I love that, because it's almost sitting on the fence by saying, well, actually, you've got a third chance of being in one of the three groups. I think the other thing is that the decision for a joint replacement isn't just on clinical symptoms. It's, are they fit enough for surgery? Are they going to be able to comply with their rehabilitation? As well as, do the symptoms really warrant this or not? So there's lots of factors involved with that. I think you're right, though. I think we are definitely getting better around selection of patients. I think what we're doing from a research perspective is we're developing better capabilities about saying, well, actually, how can conservative management work more effectively, so that those people entering into the surgical route will hopefully be reduced slightly. So if we take the example of the Escape Pain Programme, Mike Hurley's Escape Pain Programme, good clinical outcomes, good clinical cost effectiveness data as well, being rolled out across the country now, supported by various different organisations.
They've got an app, I think, which has gone live recently. Is that right?
Is it?
I think we had somebody from, is it the Arthritis Research Council that are sponsoring those guys as well? They talked about getting an app online, which might be worth some of the clinicians out there having a little look at. It's for patient use as well.
Yeah, as a program, it's really good, because it really, and many people will know about it, but it follows that physiotherapy components around exercise, about education, but also actually about self-management, behaviour change type components. So really supporting patients to improve their self-efficacy. The thing that it does also do is it really makes clinical services provide the 8 sessions or 12 sessions, I can't remember how many, but it's a fair chunk of rehab, where there's many services that won't provide that level of rehab, and that is often a barrier for its adoption. But actually, the evidence suggests that it works. And from an NHS perspective, if one service works, it will take the pressure off other services, most notably primary care, because this group of patients will have continuing direct NHS costs and NHS resources, but also the indirect effects about, actually, if your patient's pain's managed, then they're more active. That might have an implication on their diabetes and their cardiovascular disease and other factors. So I think we've got better about managing that, and the evidence base is around supporting interventions like that. So those people that don't satisfy that don't do well after that program, and being supported with such a program or programs like that, then hopefully they're the ones that really do warrant the joint replacement because they're exhausted. And I think my own personal concern is that people will go to rehabilitation, to go to therapy, and they won't have a really good crack at nice guideline physiotherapy. They might be seen once, they might be given a leaflet, they might be given a few exercises, and then discharged just because that's all the service can provide for them. And I just think it's a missed opportunity. And no wonder these patients don't do very well. So they then pitch up to the orthopaedic surgeon. The surgeon will ask, have you been to physio? The patient says yes, because that's strictly true.
They've been
once,
and
I say, yeah, and that's it. So then they're a surgical candidate. Whereas actually, if you go back a little bit and look at what intervention they got, I'd be worried about making the yes, you're a surgical candidate if they haven't had a really good go at a good program. And I think that's our challenge in a way is in physiotherapy is promoting what we do to commissioners to say, look, there's good value for this, patients like it, but also it has a knock-on effect at surgical numbers, which will have an implication from a cost perspective, let alone from a quality of life perspective for that group of patients.
So we need to be championing that.
Sorry?
We need to be championing that to the CCGs, to the commissioners, to people involved in that, because as you say, it takes the stress and the burden off other services and it's not cheap to have your knee replaced.
No, absolutely. But I think the challenge is two different pots of money. And so therefore one group will be interested in their pot of money rather than the other group. And if the other group makes savings, that's fantastic. They'll spend the money on something else, but it won't feed back or inform into the first pot of money. And that's, in the whatever the health sector, that's the difficulty, isn't it? Is that it doesn't matter if you make savings in one group because you have to make a greater expenditure in the other group. And that's unfortunately a challenge in some health sectors such as the UK. So, yeah.
And so we've talked quite a bit about the championing of self-management, of behavioural change strategies to get people on board with more physical activity, and arguably, physios need to do a better job if they can within the service that allows for it to see people more as a follow-up and to help them if they feel like they've hit a brick wall in terms of their care. And I've kind of selfishly pushed my personal questions to the end of this session because I work in intermediate care where sometimes that decision to refer on to surgery is made with me and that person in front of them. And unfortunately, I didn't have so much experience in the orthopaedic world, so I did a 6-week elective placement in orthopedics, and that was it. So I have minimal experiences as to what happens next. So if we can we talk a little bit about working somebody up to surgery and then what happens next? And I suppose my first question would be, do you use personally measures things like cold hyperalgesia, quantitative sensory testing, 2-point discrimination as a means of identifying someone who may have a risk of poorer outcomes from surgery?
I don't personally. I know if you take QST, for instance, from a neuropathic perspective, but also for a neurotesting perspective, there's some evidence, isn't there, that QST is valuable for chronic pain and discriminating between certain subgroups of chronic pain. I when predicting who's going to have a good outcome or not, that's really challenging. I think the Corker trial is a trial which Professor Karen Barker is she's just about to finish recruitment. It's based at the University of Oxford here, and this is an NIHR HTA trial which is looking at how do we rehab people who have a poor outcome? Can we identify that group early? And the group from Ashley Blom from Bristol and Nigel Argent based here in Oxford, again, have done various pieces of work around trying to identify who's at risk of a poor outcome. So there's factors such as duration of symptoms, for instance, before their joint replacement as being key, degree of anatomical abnormality from a malalignment perspective might be key. Age doesn't necessarily seem to be a factor, but certainly duration of symptoms and pain seem to be key factors as well.
As in, the longer they've had it, the more at risk they are of poor recovery.
Absolutely,
Which
yeah.
brings the question up is then, well, when's the right time? Do we not just go in straight away and replace a knee, or
And again, that's a really tricky question, isn't it? I mean, again, if we look at the evidence currently, it suggests that you're more likely to have a slightly poor outcome if the longer you've had your pain and the greater severity of the pain, and that would make sense, wouldn't it, from a biomechanical perspective? The muscle architecture, the ligaments, the malalignment levels are all going to be very different for someone that's had a degenerative condition for 20 odd years versus 5 years. Your rehab's going to be more challenging potentially. So that would make sense. But then you then have the flip side, which is, well, do you really want to do a knee replacement on someone who's 45, knowing full well that they'll need their first revision at 60, their second revision at 75, their third revision at 90, whatever, and the subsequent risks of each of those operative procedures. So that's really individual question. That's to go back to that's that individual question about the patient, their quality of life, the surgeon's advice, and the orthopedic physio and the physio's advice as well, really. So that's challenging. So the question of when is the right time it's very individual, and ultimately that shared decision making has to be done, really. But we certainly know that if you've got severe symptoms and you've had them for long, then surgically it's a more challenging operation, and your rehab is often a more challenging rehab. So we can identify to a certain degree based on clinical features and demographic features, maybe less than the sensory testing type stuff, that people who aren't going to do well. Okay. Now, in reality, though, in current clinical practice today, there's very few services that I know of that will say, okay, preoperatively, you're at high risk. We're going to have a different rehab program for you versus anybody else. So many centres across the country will have a hip or a knee school that have some form of education and advice. And that might vary from a formal prehab session of 6 weeks of exercise, or singing or dancing, versus an afternoon with a cup of tea and a leaflet, telling them about what to expect from their enhanced recovery program during their operation, and maybe a little bit about what to expect afterwards. But there'll be nothing, there'll be no formal group sessions after that, really. So massive disparate variability across the country about the preoperative workup of this group of patients, really, irrespective of whether they're going to do well or not, really. So,
something to look into then for you, Toby. Add it to the list.
It is certainly adding to the list, and I know it's something that NICE want to look at as well, because they're well aware that there is an evidence base around prehab and around formally giving people exercises and working them up so that they're stronger and have greater exercise tolerance. But yet there is massive variability across the UK, and this variability really is just unfair for patients if there's a good evidence base for it. So that's something that the group will be looking at.
And so let's say we found that magical person, that it is the right time for them to have that knee replacement, and everybody's singing from the same hymn sheet, and we decide to write that letter off to the orthopaedic surgeon. What's on offer nowadays in the NHS? What can you have done?
So it all depends on I suppose it all depends on your clinical perspective and also from the surgeon's perspective. So I suppose from a surgical perspective, if your patients, if they present with single compartment osteoarthritis, medial compartment osteoarthritis, some surgeons will say, okay, we can do a unicompartmental knee replacement for this patient. Some surgeons will say, no, we'll do a total knee replacement for this population, and depending on their surgical decision making, based on their skill set, what they do, what they know works well for the patient, based on their viewpoints about the potential trajectory that this patient might develop bi-compartment osteoarthritis or not. If it's isolated patellofemoral osteoarthritis, there's an option about having a patellofemoral joint replacement on its own, such as an Avon or something like that. But then there's some orthopedic surgeons that will say, well, chances are you're probably going to develop in the next year or two OA in your medial compartment and lateral compartment. We'll do the whole thing to prevent that happening or not.
I was going to ask you about that crystal ball that they have in secondary care about you're going to need another one done in 5 years.
It's really, it's funny. I looked at the evidence recently around that, and the evidence, unsurprisingly, is fairly sketchy. But there was this cohort that they did in America, and they looked at that question. They found that of all the people that had a total hip replacement, they were looking at of over a 10-year period, those that had a unilateral total hip replacement, 41% developed osteoarthritis in their bilateral hip over that 10-year period, and of that, 19% then went on to having a contralateral total hip replacement. So I'll see you in 5 years' time for another hip replacement. Well, that only actually worked in 10 years for a very small number of that patient group, really.
It's a win-win. It's a win-win statement, isn't it? You either have the hip done and you think this surgeon's a genius, he predicted it to the day, or you don't, and so you think, oh, I dodged that bullet.
No, yeah, exactly. Depends on a pessimist or or the alternative. Yeah, no.
So we talked about the things that are on offer.
Yeah.
We mentioned there's a unicompartmental replacement, a patellofemoral replacement, a total knee replacement. One of the questions that I often get asked is, well, maybe not in these words, but how robust are these things? What can I do afterwards?
Yeah, absolutely. And it's a really good question. And it's a question, I think, which is core to every physio who rehabs this group of patients as well. Knees are bomb-proof, or they should be bomb-proof, okay, almost. So if we take the hip, for instance, so we know, I'm not even going to venture on the whole instability, dislocation, precautions event, but with the knee, the patient should be encouraged actually this, as long as the operation has gone well, it is solid, it's stable, nothing should go with it. Your knee will tell you if it doesn't like doing certain things. So historically, patients don't like kneeling, and they always have a challenge with kneeling. It was interesting. There was Kathy Jenkins, who's one of the research physios based over at the Nuffield Orthopaedic Centre. She did a study looking at whether patients could kneel or not after a half knee replacement, after a uni knee replacement, and she found actually if you taught people, if you showed them they could kneel in the first 6 weeks or so, then a large proportion would do, but they'd try it once and then avoid it forever and ever and ever and a day. So it's one of these things. But knees, they are, resilient. You can do lots on them. You can do all the things that you really, really want on them, really.
Including
they will
sport?
tell you if they're not happy or not.
If someone was a 45-year-old, like you say, early knee replacement, can they return to sport? Can they return to recreational running? Can they get on the rugby pitch every now and again? Where would you draw the line?
Where would I know? And it was funny. There was something on Twitter about this last night around someone who's going to have a hip replacement, about whether they can return back to sport or not. It's really hard because, again, I'm a clinical researcher, so if I go back to the evidence, there's some papers that suggest that this group of patients return back to sport. It has no effect on the longevity of their joint. And if we think about the implant itself, we've got a surgical stainless steel with a plastic polyethylene cup or tray at the bottom of it. The wear rates are really, really low, and however it's being implanted, it should be fairly solid. So returning back to sport, I think, is very important. I think it's being very clear to the patient to say, look, the evidence base is really uncertain about this. We've got no really good evidence that suggests that you returning back to sport will wear it out quicker. But likewise, we've got no evidence to say it won't wear it out quicker. It is that decision on that patient. So first of all,
keep in touch and we'll do a case study.
Yeah, absolutely. Yeah. I think the first question, I suppose, is what do they want to return back to, and can they return back to that? So returning back to tennis and golf, cycling, jogging, I think is all realistic. Returning back to football and rugby might be more challenging, but in all fairness, people are phenomenal, aren't they? And if they really want to return back to something, they'll give it a jolly good go, really. I think, I always go back to what would I do if it was me? And if it was me, I probably wouldn't return to football and rugby, just because knowing my luck, someone would go and tackle me and then I'll end up with a tibial fracture or a femoral fracture. And then, fixing that with a periprosthetic fracture with a joint above and below or either is more challenging. Whereas if I'm running or if I'm cycling, well, it's just jolly unlucky that I've been knocked off my bike or knocked off running, but my risks are lower. So I'd be probably more inclined to return back to that. At the end of the day, I'm one of these physios, and I hate telling people not to do stuff. So it's more about, okay, well, what can we do to try to support that? This is what could happen, and for your overall health, your overall well-being, give it a go. So I remember I bumped into someone at the weekend, and she said her physio told her not to do Zumba, and I said, well, yeah, but you really like Zumba. It's a big social part for you. It's really healthy, and that's what makes your Wednesday evening fun. And she said, yeah. I said, well, just go back and just ask her, well, why? What part of Zumba are you not sure about? Is that forever? Is that just for a certain period of time? And what can I do? Because I really like it, and can I return back to that? And can we break it down? Or is there anything I can do to try to make that easier to happen? Really, in a progressive exercise way. So I say nothing's impossible, but it might have an implication. But we're not clever enough yet, really. But yeah, I like getting people back, and I like proving that actually people can. And with a hip replacement and a knee replacement, I think we're very cautious, largely because of uncertainty. I think if we knew the answer, we wouldn't be so cautious, or we'd be more confident about our recommendations. But because there's so much uncertainty, physios and surgeons always feel worried about that. And I suppose from a surgical perspective, they're inclined to wrap people up in cotton wool because they don't want anything to go wrong with their operation, because the patients come in and the surgeon's done a really good job in fixing that. And many surgeons will be like, well, let's err on the side of caution, which I can understand from a surgical perspective. But other surgeons are like, actually, no, it's important to you, speak to your physio, or work it out for yourself, and aim to go back to that. And there's a greater flavour for people encouraging greater physical activity, because the evidence around being active is so compelling now that every healthcare professional knows it's important to do. So
yeah, and I think you don't want to be that mug that goes, yeah, go on, crack on, mate, and then they sit in front of the surgeon after an untoward incident from returning to the playing field. We have
Absolutely.
Historically been a little bit all or nothing, haven't we, when it comes to advice on activity? And I think that Zumba example is a great example of that. Well, okay, can we pick apart what does your activity comprise of? Can we do some of it rather than none of it? Because, like you said, there's a big social aspect to exercise. But I think I've probably kept you long enough. You said you had to be away by 11:30, and I suppose we're knocking on that time. And those with good hearing might be able to hear in the background that my newborn is getting a little bit unsettled. It's not a cat, I promise. It's a 4-week-old child. So I think we'll wrap this up, Toby. But before we do, is there anything that you'd like to draw our attention to? Anything you'd like to highlight? Any work that you do? Anything you'd like to plug?
No, I think just keep looking out, really. I mean, I think the work, as we talked about right at the start, around the MREC outcome measures would be really important. As a group, we're continuing to look at physical activity and trying to look at wider physical activity and health promotion for people after joint replacement, but also after joint fracture as well. So it's a really exciting time in UK research and musculoskeletal research, and particularly in trauma orthopedics. So just keep watching this space. But thanks for the opportunity.
No problems. Good to have you back on, Toby. Unfortunately, not face to face. We met back in Oxford a few years ago as we did the Sally Lamb project, and hopefully our paths will cross again. But yeah, thanks very much for taking the time, and hopefully this has been useful to the people listening.
That's great. Thanks a lot, Rob.
Okay. Cheers, mate.
Well, there you go. Thank you very much to Rob and Toby for that really brilliant podcast. I know I found it useful again. I'll be going back to listen to the hips session for a third or fourth time, I think, to really get as much information out of Toby as I possibly can. I really think that the message regarding exhausting conservative care is a super important one. My philosophy is, if you didn't go to physio and come out exhausted, then you haven't really exhausted conservative care. So that, coupled with the pain medication and all those sorts of extra stuff that Toby was mentioning, I think is really important, so that the right people end up going for their knee replacements and they don't go too soon, because, as mentioned, all the complications and poor outcomes that potentially could happen would be mitigated if people have managed to exhaust their conservative care properly. Please get in touch with us with any feedback. We always love to hear from the listeners, positive or negative. It all helps us to move forward and improve the show month on month. If you want to contact us by email, inquiries@choosehealth.co.uk is the easiest way to get us. We're all on Twitter, so any direct questions to @Toby O Smith. Rob is at Combat Sports Phys. I'm at PhysioJack for all your rheumatology needs. And of course, the podcast team, which is the feed is also run by me, at TPM Podcast. Have to give a nod to exerciseprescriber.com, who've once again sponsored us for this episode. They've sponsored us for a number of episodes this year, which we are grateful for, and it's keeping us on the air and out of the food banks. So if you follow them at EXPrescriber and go to their website at www.exerciseprescriber.com, you can sign up for a 2-week free trial, and you get access to almost all of the website for that, and all of the functionality. I've been using it in clinic and I've had some great feedback from the patients on their end, and I find it super user friendly and can't have any complaints about it particularly at all. I hope that we can keep the quality high over the next 50 episodes. I'm sure you'll be pleased to know that Mr. Chew will be back with his long-winded questions and long introductions and conclusions at the end of every episode for next month, as he's back from his honeymoon. I've really enjoyed being here doing this and getting to do the editing of the podcast once again, and hopefully I will be back soon. We will all see you next month. Thank you very much. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters.